Over the last decade, the interest in hip arthroscopy has grown significantly. Arthroscopic hip procedures have emerged that can successfully treat conditions previously gone unrecognized or only treatable with open procedures. Hip arthroscopy is associated with minimal morbidity and a potentially quicker return to activities in comparison to open approaches when careful attention is paid to patient selection and surgical technique. This video will focus on patient workup and patient selection, which may be the most critical part of achieving excellent outcomes in patients undergoing hip arthroscopy. The typical history, physical examination techniques, evaluation of imaging studies, and appropriate indications and contraindications will be discussed, allowing the surgeon to identify appropriate patients and to ultimately maximize outcomes after hip arthroscopy. A patient history is the first step in creating a differential diagnosis for patients presenting with hip and pelvis pain. There are a number of findings by history that can help to direct the physical examination and imaging workup and ultimately lead to a diagnosis and selection of appropriate patients for arthroscopic hip procedures. Initially, the clinician should inquire about when the discomfort began and whether this came on gradually or was the result of a traumatic episode. It is important to inquire about the primary location of pain with respect to the groin, lateral hip, posterior hip, buttock, or low back pain, and whether the pain is palpable or deep. The term hip is extremely variable with respect to location when talking to patients and referring clinicians. It is imperative to inquire about the type of pain with respect to sharp mechanical pain versus aching pain. Patients with hip pain amenable to hip arthroscopy typically have intermittent sharp pain with torsional activities, such as getting in and out of a car, during cutting and pivoting athletic activities, putting on shoes and socks, and occasionally when getting up from a seated position. In addition, patients may note findings consistent with range of motion limitations, such as a history of inability to sit with their legs crossed or in a figure of four position. Aching pain at rest, especially aching that wakes a patient or keeps a patient up at night, may be a poor prognostic indicator and more consistent with advanced degenerative hip disease. Inability to walk straight ahead for short distances may also be more indicative of advanced degenerative hip disease. Aching pain with prolonged hip flexion or sitting, or after performing rigorous sporting activities, however, can be consistent with intra-articular pathology and hip impingement in the absence of significant degenerative changes. Paresthesias, radicular pain, and the radiation of pain about the hip and pelvis and down the leg should also be noted. One should inquire about any painful anterior or lateral painful snapping that would be consistent with internal or external snapping hip. Asymptomatic snapping is fairly common and generally requires no further treatment. Feelings of giving way may be indicative of unstable chondral or labral pathology, loose bodies, or alternatively seen with structural instability in the setting of dysplasia or prior hip subluxation or dislocation. Although loose bodies can result in intermittent true locking of the hip joint, this finding can also be seen in the setting of a snapping hip or unstable chondral and labral pathology. It is important to ask whether an anesthetic or therapeutic injection has been performed in the hip joint proper and whether the patient noted significant relief of their usual symptoms in the first several hours as opposed to the next several days or weeks. If no relief was noted, one should inquire as to whether the patient was having their typical pain at the time of the injection or whether they performed the typical inciting activity immediately after the injection. The clinician should also inquire about any other diagnostic injections performed, the specific location such as the SI joint, epidural injections, symphyseal injections, psoas and trochanteric bursal injections, and the temporary response to these injections. Prior physical therapy regimens and the specific protocols or techniques performed should be noted, and whether these treatments resulted in improvement, no change, or even worsening of their presenting complaints. It is not uncommon for patients with hip impingement to worsen with a physical therapy program focusing on restoration of range of motion and deep hip flexion weight training, as these techniques can lead to further impingement and worsening of symptoms. The degree of disability or loss of performance as a result of the hip pain should be ascertained. For example, it is reasonable to recommend surgical intervention for an athlete who is unable to perform effectively as a result of their hip pain. It is much more difficult, however, to entertain surgery for athletes who maintain their activity at a high level with little effect on performance despite hip discomfort. It may be advisable to proceed with caution in this situation rather than immediately recommend a procedure that could potentially result in failure to recover their preoperative functional ability. Prior surgical procedures performed, such as intra-abdominal exploratory surgery, spinal fusions, SI joint fusions, and sports or athletic pubalgia surgeries, and any relief or lack thereof should be noted. A remote personal or family history of hip pain and associated procedures performed should also be noted. Finally, one should inquire about the recent use of narcotics for their presenting complaints, workmen's compensation cases, and pending litigation, as these can all be poor prognostic factors with any potential treatment options entertained. A thorough physical examination can help to confirm pathology or injuries indicated by history and imaging studies. Gait evaluation, palpation, range of motion assessment, and a number of specific examination tests should be performed as part of a complete physical examination. It is imperative to be competent examining both intra- and extra-articular hip and pelvis structures, as associated disorders frequently mimic each other and can coexist.
An antalgic gait is an abnormal gait secondary to pain. This typically results in a shortened stance phase of gait as seen here. This may be secondary to hip subluxation, advanced stress fractures, significant degenerative joint disease, acute muscle strain, and apophyseal injuries. Pathology amenable to hip arthroscopy does not typically result in a severely antalgic gait. This gait pattern is secondary to hip abductor weakness. When placing weight on the affected leg, the contralateral hip drops as seen here. This can be the result of an abductor tear, neurologic disorder such as a superior gluteal nerve abnormality, or severe hip abductor deconditioning. With hip abductor deficiency, one may also observe an abductor lurch during gait. This gait pattern is seen here, and the patient typically has a shortened stance phase while leaning the upper torso over the affected leg. Internal rotation can be tested in the supine position by flexing the hip to 90 degrees with neutral abduction and adduction, and internally rotating the hip until a firm endpoint is felt or to pain tolerance. Internal rotation can also be evaluated in a seated position and is important to stabilize the pelvis, which has been done in the current video with a strap around the thighs. Normal internal rotation is typically greater than 20 to 30 degrees. Limited hip internal rotation is consistent with hip impingement. Decreased internal rotation with increased external rotation is consistent with femoral neck retroversion, whereas increased internal rotation with decreased external rotation is consistent with excessive femoral neck anaversion. External rotation can be tested in the supine position by flexing the hip to 90 degrees with neutral abduction and adduction, and externally rotating the hip until a firm endpoint is felt or to pain tolerance. External rotation can also be evaluated in the seated position and is important to again stabilize the pelvis as discussed with internal rotation. Normal external rotation is typically greater than 40 degrees. Limited external rotation with increased internal rotation is consistent with excessive femoral neck anaversion, whereas increased external rotation with decreased internal rotation is consistent with femoral neck retroversion. Forward flexion is tested in the supine position with neutral abduction and adduction. It is important to control for lumbar tilt and to keep the contralateral hip extended. The hip is flexed maximally to a firm endpoint or to pain tolerance. The examiner can also ask the patient to grab their knee and maximally flex the hip. Normal forward flexion is typically greater than 120 to 135 degrees. Significant limitations in forward flexion and internal rotation are consistent with hip impingement, whereas more global limitations in range of motion are consistent with advanced degenerative arthritis. Less frequently, however, limitations in hip range of motion can be associated with adhesive capsulitis of the hip. Abduction is typically tested in the supine position with the hip extended. One hand is used to palpate the contralateral anterior superior iliac spine, and the other hand is used to abduct the hip. Maximal hip abduction is achieved when the contralateral anterior superior iliac spine begins to move, indicating end range of motion. Normal abduction is greater than 30 to 45 degrees. Adduction is tested in the supine position with the hip extended. One hand is used to palpate the contralateral anterior superior iliac spine, while the other hand is used to adduct the hip above the contralateral hip until the anterior superior iliac spine begins to move, indicating end range of motion. Normal adduction is typically greater than 20 degrees. The Thomas extension test is performed in the supine position. The contralateral hip is maximally flexed, and at that point, the ipsilateral or affected hip is evaluated for a hip flexion contracture. A hip flexion contracture is present when the affected hip does not lie flat on the examination table. Range of motion can give insight to underlying pathology and help define the underlying anatomy. Range of motion should always be compared to the contralateral side. Increased internal rotation with decreased external rotation can be indicative of increased femoral neck anaversion. Decreased internal rotation with increased external rotation can be indicative of femoral neck retroversion. Markedly decreased internal rotation and forward flexion can be seen in the setting of femoral acetabular impingement or structural impingement, whereas global restrictions in range of motion are more often associated with advanced degenerative hip disease or less commonly adhesive capsulitis of the hip. Obligate external rotation and abduction with forward flexion testing can also be indicative of hip impingement. Markedly increased range of motion and hypermobility can be seen in the setting of hip dysplasia and structural instability. Although intra-articular hip pathology is not typically palpable, there are specific areas surrounding the hip joint that can mimic hip joint pathology and coexist with hip joint pathology. It is helpful to ask the patient point to the typical area of pain. Evaluation of the greater trochanter and associated muscle insertions begins by outlining the greater trochanter with the patient in the lateral position. The anterior aspect of the greater trochanter is the site of the gluteus minimus attachment. The mid and superior portions of the greater trochanter is the site of the gluteus medius attachment, and the posterior aspect of the greater trochanter is the true site of trochanteric bursitis and is devoid of any muscular and tendinous attachments. Greater trochanteric pain syndrome is often associated with other pathology about the hip, pelvis, and low back, or less commonly exists in the absence of other disorders in the setting of abductor tears or deficiency. Examination for athletic pubalgia or sports hernia type symptoms begins with identification of the inguinal ligament and palpation of the external obliques. This is followed by palpation of the conjoined tendon or rectus abdominis insertion onto the pelvis. Next, the pubic tubercle and pubic symphysis are palpated. The hip is then flexed and adducted in order to palpate the adductor and pectineus origins, followed by resisted hip adduction in order to elicit pain related to these structures. Finally, the patient is asked to perform a sit-up or crunch while palpating the rectus abdominis insertion. Complete evaluation includes an evaluation of the inguinal ring and posterior inguinal region, which is typically performed by an experienced general surgeon. Athletic pubalgia or sports hernia type symptoms can coexist with intra-articular pathology and in particular with femoral acetabular impingement in a subset of athletes. It may be that the range of motion limitations associated with hip impingement lead to compensatory patterns around the pelvis and trunk, leading to this association. Palpation of the ischial tuberosity is performed in the prone position. Pain in this region can be secondary to proximal hamstring tendinopathy, partial or complete ruptures of the hamstring origin, or secondary to apophysitis or apophyseal avulsion in adolescence. The iliac crest should be palpated and can be the source of pain for patients with iliac apophysitis or apophyseal avulsions, abdominal oblique strains, and hip pointers. The anterior superior iliac spine can be painful secondary to apophysitis or apophyseal avulsions, sartorial avulsions, and is a critical landmark used during hip arthroscopy. Abduction strength testing can be assessed in the lateral position. The patient is asked to actively abduct against resistance. Weakness can be consistent with core strength deficits or less commonly abductor disruptions. Pain can be indicative of abductor tendinopathy or strain injury. Adduction strength can be tested with the patient in the supine position with the hip and knee flexed. The patient is asked to adduct the leg while the examiner resists adduction while palpating the adductor and pectineus tendons. Pain and or weakness can be the result of complete or partial adductor tears and tendinopathy. Hip flexion strength can be assessed in the supine position. Forward flexion is tested with the hip and knee in extension, as well as with the hip and knee in 90 degrees of flexion. Pain with resisted flexion can be secondary to hip flexor and lower abdominal tendinitis or strain injuries, or alternatively can be secondary to hip joint pathology in some cases. Hip extension can be tested in the prone position. The patient is asked to extend their leg off of the table while the examiner resists hip extension and palpates the gluteus maximus during the contraction. Gluteus maximus weakness and associated core deficiencies are common findings for patients presenting with hip joint pathology. Much of our rehabilitation for these patients focuses on recruitment of the gluteus maximus. The FADDIR or anterior impingement test is performed with hip flexion, internal rotation, and adduction. Initially, this is performed at 90 degrees of hip flexion, and if no pain is elicited, further flexion, internal rotation, and adduction is then performed. This is considered positive when it recreates the patient's typical groin pain. It is important to verify that this recreates the presenting complaints anteriorly and should be compared to the contralateral side. A positive test indicates anterolateral rim or femoral pathology. This test is used to assess for appropriate bony resections intraoperatively as well. The posterior impingement test is performed with the contralateral hip inflection to neutralize lumbar lordosis with the affected hip extended and externally rotated. This may recreate the patient's typical deep lateral or posterolateral pain, which is consistent with posterolateral rim or femoral pathology. FABERs or the Flexion Abduction External Rotation Test is traditionally performed to diagnose sacroiliac joint pathology. It is performed with hip flexion, abduction, and external rotation. Patients with anterior groin or deep lateral pain and an increased distance from the table to the lateral knee with this maneuver may have associated intra-articular hip pathology and femoral acetabular impingement. Alternatively, patients with a tight and painful psoas tendon can also have groin pain with this test. The DEXTRIT, or Dynamic External Rotatory Impingement Test, is similar to the traditional McCarthy's test. The patient is in the supine position with the contralateral hip flexed greater than 90 degrees. The affected hip is flexed and brought through a wide arc of hip external rotation, abduction, and extension. This test is considered positive when it recreates the patient's typical groin or deep lateral pain. The DIRIT, or Dynamic Internal Rotatory Impingement Test, is performed with the patient in the supine position. The contralateral hip is flexed to greater than 90 degrees, and the affected hip is flexed and brought through a wide arc of internal rotation, adduction, and extension. The test is considered positive when it recreates the patient's typical groin or deep lateral hip pain. The Scour test is performed in the supine position with the contralateral hip flexed greater than 90 degrees. This test combines the DEXTRIT and DIRIT tests with the addition of axial compression. The hip is moved through an arc of motion from flexion, adduction through extension, abduction. The leg is moved clockwise and counterclockwise with a compressive force. This test is considered positive when it recreates the patient's typical groin or deep lateral hip pain. The patient actively flexes their leg 30 to 45 degrees while lying supine. The examiner then resists further flexion while applying pressure to the thigh just proximal to the knee. The test may load the anterior superior labrum. The abduction internal rotation test is considered to be positive when this maneuver recreates a patient's typical groin or lateral hip pain. Pain with this test is consistent with more superior areas of hip impingement. This test can be helpful to evaluate patients involved in repetitive abduction, such as equestrian and motocross riders, as well as cross-country skiers, and can be performed intraoperatively to evaluate appropriate bony resection. The butterfly Goalie test is performed with the patient in the supine position. The hip is flexed, internally rotated, and abducted. Pain with this test can be consistent with anterior superior and superior-posterior areas of impingement. This is one of the tests used to evaluate appropriate arthroscopic bony resection intraoperatively. This test is performed with passive internal and external rotation of the limb with the patient in the supine position with the hip and knee extended. Pain with supine log rolling testing has also been shown to be specific but not sensitive for diagnosing hip joint pathology. Our experience has been significant pain with log rolling activity indicates extreme capsular irritability. In addition, increased passive external rotation by more than 10 to 20 degrees compared to the contralateral side may be indicative of capsular laxity or capsular instability in the absence of bony version abnormalities. This is a variant of the description by Thomas Bird. Instead of the patient indicating the region of pain, the examiner simply grabs the anterior and posterior aspect of the greater trochanter and asks if the location of pain is between their fingers. We have found this to be quite useful and indicative of intra-articular hip pathology. The apprehension test is performed with the patient in the supine position and the contralateral hip flexed. The affected hip is extended and externally rotated. Anterior pain and/or apprehension can be consistent with structural hip instability or dysplasia, whereas posterolateral pain may be more consistent with posterior impingement. In the setting of structural instability, the hip can be flexed, abducted, and internally rotated, and relief of apprehension can further confirm the diagnosis in some patients. Snapping secondary to external or iliotibial band snapping can be reproduced in the lateral position with the affected hip up. With the hip in slight adduction and the knee in flexion, flexion and extension of the hip can reproduce the snapping. Alternatively, patients are often able to recreate the snapping on their own while standing and internally and externally rotating their hip. The patient is positioned in the supine position with the contralateral hip in flexion. The affected hip is brought from a position of flexion to extension, or alternatively, from a position of flexion, abduction, external rotation, to a position of extension, adduction, and internal rotation. These maneuvers will typically reproduce an anterior clunk or thug as opposed to a click. If the patient can reproduce their snapping on their own, the examiner can simply place their hands over the anterior hip and the snapping will be felt, confirming the diagnosis. If radiographs are normal and a stress reaction of the proximal femur is suspected, the patient can perform a gentle single-leg hop test. Groin pain with this maneuver may be more indicative of hip or pelvis stress fracture as opposed to pain with torsional maneuvers associated with intra-articular or labral pathology. This test should not be performed if a fracture line, in particular on the tension side of the femur, is visualized at the femoral neck on imaging studies. While standing, the patient actively performs contralateral hip and knee flexion to approximately 45 degrees and maintains this position. An eventual drop of the contralateral hip is a positive test and indicative of abductor deficiency. Ober's test is performed with the patient in the lateral position with the affected side up. The examiner stands behind the patient and cradles the leg to assess passive hip adduction. This assesses contractures of the iliotibial band with the knee extended and abductors with the knee in flexion. The hip should normally passively adduct beyond neutral with this maneuver. Hypermobility testing can help to further define the pathology present. Baton's criteria defines hypermobility when 3 of the 5 of the following are present: the ability to touch the thumb to the forearm, 5th digit hyperextension beyond 90 degrees, elbow hyperextension or recurvatum beyond 10 degrees, knee hyperextension or recurvatum beyond 10 degrees, and the ability of a patient to touch their palms to the floor.
The ability to appropriately evaluate imaging studies for the painful hip is necessary to understand the potential pathologic forces at work. A detailed evaluation of imaging studies will be reviewed, which will assist in making an accurate diagnosis and ultimately guide treatment options for these patients.
Evaluation of plain radiographs begins with an appropriately centered anterior-posterior pelvic radiograph with the coccyx centered over the pubic symphysis, 0 to 2 centimeters between these structures, and symmetric obturator foramina. The lateral center edge angle of Weiberg is measured by drawing a line connecting the inferior aspects of the teardrops. A second line is drawn parallel to this line and through the center of the femoral head. A third line is drawn from the center of the femoral head and perpendicular to line 2. A fourth line is then drawn from the center of the femoral head to the lateral aspect of the sourceal. The angle formed by lines 3 and 4 is the lateral center edge angle and is typically 25 to 35 degrees, with lower numbers indicating acetabular dysplasia and significantly greater numbers indicating acetabular overcoverage. The tonus angle is measured by drawing a line through the inferior aspects of the teardrops. A second line is drawn from the medial aspect of the sourceal and parallel to line 1. A third line is drawn from the medial aspect of the sourceal to the lateral aspect of the sourceal. The angle formed by lines 2 and 3 is the tonus angle and is normally 0 to 10 degrees, with lower numbers consistent with structural impingement and higher numbers consistent with structural instability. The alpha angle is measured by first drawing a circle around the femoral head. A line is drawn from the center of the femoral head and parallel to the femoral neck. A second line is drawn from the center of the femoral head perpendicular to the first line. A third line is then drawn from the center of the femoral head to a point where the femoral head-neck junction falls outside of this circle. The angle between the first and third lines is the alpha angle and is normally less than 43 to 55 degrees depending on the literature cited. Numbers greater than 60 degrees are consistent with radiographic cam-type impingement. The crossover sign is evaluated by drawing a line along the anterior and posterior acetabular walls on a well-aligned radiograph of both hips. This is considered positive when the anterior wall crosses lateral to the posterior wall. This indicates anterior overcoverage when associated with normal posterior acetabular coverage, or acetabular retroversion when associated with a deficient posterior acetabular wall. Positive ischial spine sign is present when the ischial spines are identified within the pelvis or medial to the superior pubic ramus. This is consistent with acetabular retroversion. A positive posterior wall sign is present when the center of the femoral head lies lateral to the posterior acetabular wall. This indicates posterior wall deficiency and acetabular retroversion when associated with the crossover sign. Protrusio acetabuli is present on a well-centered AP pelvis when the medial aspect of the femoral head lies medial to the ilioischial line. Coxa profunda is present when the teardrop lies medial to the ilioischial line and is sometimes associated with ossification of the labrum as indicated by the arrow. A 45-degree modified Dunn view is useful to better evaluate cam-type impingement. The alpha angle should be measured on the lateral view as described previously. A cross-table lateral radiograph is also useful to evaluate for cam-type impingement and allows for visualization of the joint space anteriorly and posteriorly. It is helpful to get a false profile view, which allows you to measure the anterior center edge angle. The anterior center edge angle is measured by drawing a horizontal line from the center of the femoral head. A second line is drawn from the center of the femoral head and perpendicular to line 1. A third line is drawn from the center of the femoral head to the lateral aspect of the sourceal. The angle formed by lines 2 and 3 is the anterior center edge angle, which is normally greater than 20 degrees. Lower numbers are consistent with anterior acetabular dysplasia, whereas significantly greater numbers are consistent with anterior acetabular overcoverage. Magnetic resonance imaging is useful in order to evaluate intra-articular hip pathology. MRI arthrogram has greater sensitivity for identifying labral tears compared to non-arthrogram studies. Chondropathology is not as accurately defined by MRI, regardless of the technique. MRI can identify labral tears, chondral pathology, ligamentum teres injuries, synovial disorders, loose bodies, cam lesions, and acetabular version. Newer MRI techniques, including degemerate scanning, may allow for better assessment of chondral pathology in the future. An MR arthrogram also allows for the inclusion of an anesthetic injection in order to confirm the hip joint proper as the source of hip pain. Three-dimensional CT scanning is invaluable to characterize hip impingement. Os acetabuli and pincer-type impingement, as well as cam lesions, can be identified in 3 dimensions. In addition, the site of the superolateral retinacular vessels and proximity to cam lesions can also be identified. Axial images allow for evaluation of acetabular version, and the addition of slices through the distal femoral condyles allow for an additional evaluation of femoral neck version. We routinely obtain 3-dimensional CAT scans prior to consideration of surgery for patients with femoral acetabular impingement.
Once a diagnosis is reached, it is critical to understand the appropriate treatment options available. The following list of indications and contraindications are discussed in order to identify those patients with disorders that can be safely and effectively managed with arthroscopic hip procedures and those that may be best managed with alternative treatments.
Labral tears are the most common indication for hip arthroscopy. With emerging evidence that labral preservation leads to better short-term outcomes in comparison to labral debridement or excision, there has been an increased emphasis on labral repair and preservation as opposed to indiscriminate debridement or excision. It is imperative to dynamically assess the hip for associated impingement in order to protect the labrum after repair or preservation techniques. Chondral pathology is a frequent finding during hip arthroscopy. Debridement of any associated unstable chondral flaps can help to alleviate mechanical symptoms. Microfracture technique remains the preferred technique for management of full-thickness chondral injuries that are well contained. A combination of 45 and 90-degree awls, with or without a mallet, are often required to penetrate the subchondral bone and access the underlying marrow elements. Femoral acetabular impingement is a frequent indication for hip arthroscopy. The majority of the acetabular rim and anterior-inferior to superior-posterior femoral head-neck junction are readily accessible during hip arthroscopy. Acetabular rim resection with labral refixation techniques are frequently used for pincer-type impingement. Femoral resection osteoplasty is used to treat cam-type impingement. Intraoperative fluoroscopy and dynamic assessment are utilized in order to evaluate the associated impingement and adequacy of bony resections. Ligamentum teres injuries are not infrequent findings at the time of hip arthroscopy. This can be associated with degenerative hip disease, traumatic subluxation or dislocation, torsional events, and can be associated with structural instability as well. Treatment involves debridement with a shaver and/or flexible thermal device. Synovial disorders such as pigmented villous nodular synovitis and synovial chondromatosis can be approached arthroscopically. Posteriorly based synovial disorders may be better managed with an open approach. A septic hip can also be treated less invasively with an arthroscopic approach in comparison to open arthrotomy. Loose bodies with mechanical symptoms may be one of the clearest indications for hip arthroscopy. Loose bodies can be seen in the setting of early degenerative changes, traumatic chondral and osteochondral injury, synovial chondromatosis, and even seen in the setting of total hip arthroplasty as seen in the left image with a loose piece of ceramic liner. Outcomes have been excellent in this patient population, and any associated pathology can be managed concurrently. Hip arthroscopy can be performed in the setting of hip subluxation or dislocation. In this situation, loose osteocartilaginous fragments can be removed, ligamentum teres lesions can be treated, labral tears and capsular injuries can be addressed in the presence of a stable joint. Internal or psoas snapping hip and psoas impingement can be managed arthroscopically when conservative measures fail. Psoas impingement is a more subtle finding indicated by relief with a psoas bursal injection preoperatively and bruising, tearing, and adhesions between the psoas tendon and capsule at the level of the psoas U or 3 o'clock position for the right hip. The psoas tendon can be released at the level of the central compartment with traction as seen in the right video, at the level of the zona orbicularis in the peripheral compartment, or at the level of the lesser trochanter without traction as seen in the left video. The tendinous portion is released with an ablation device or arthroscopic knife. External snapping or iliotibial band snapping is frequently voluntary and relatively asymptomatic. For recalcitrant painful cases, an arthroscopic release can be performed. Recently, abductor tendon tears and associated trochanteric bursitis have been treated with an endoscopic approach. The hip abductors and trochanteric bursa can be accessed by creating a window in the iliotibial band as seen in the left video, or accessed by creating portals deep to the iliotibial band. Osteoarthritis should be approached with extreme caution. Plain radiographs will significantly underestimate the degree of degenerative changes present. Studies have shown that results are inferior in the presence of joint space narrowing and uniformly poor with less than 2 millimeters joint space remaining. We have found that a predominance of achy pain and greater than 50% joint space narrowing on plain radiographs leads to a high rate of failure after hip arthroscopy. Although femoroacetabular impingement is becoming one of the more common indications for hip arthroscopy, there are certain situations that may be better served with an open surgical approach. Moderate to severe acetabular retroversion with a volumetrically deficient acetabulum may be better managed with an anaversion periacetabular osteotomy. Protrusio acetabuli requires a more significant rim reduction, and dynamic assessment is more difficult with an arthroscopic approach. Posterior extension or posteriorly based cam lesions are also difficult to access arthroscopically and may be better managed with an open surgical dislocation. Although borderline dysplasia can in some instances be approached arthroscopically, moderate to severe dysplasia and dysplasia with a break in Shenton's line or lateralization of the femur greater than 1 centimeter should be evaluated by an open surgeon and considered for periacetabular osteotomy when appropriate. It should also be noted that anterior rim resection in the presence of a crossover sign with a deficient superior and posterior acetabulum can lead to global structural instability and should be avoided.
The role for hip arthroscopy in the management of hip and pelvis disorders continues to evolve. A thorough workup, including a detailed history, physical examination, and appropriate imaging studies can result in an accurate diagnosis for most patients. An understanding of the appropriate indications for hip arthroscopy and its inherent limitations can help to optimize outcomes in this patient population.